thousands upon thousands of explant surgeries, and you've been an expert in the field for over 20 years. What probably drew me to it the most is your holistic approach. Generally, I talk about things that are with regards specifically to men because I speak to that experience. And as I think about the work you do, it absolutely impacts men, not as much as the women.
It's obviously a big change in your spouse or your partner, a family member who has implants, whether they're cancer reconstructive purposes or cosmetic purposes, and then ultimately they have a problem and they feel like they've went through a very exhaustive medical workup and not found any answers, and then went to other kind of alternatives without exploring this option, which is a surgery that's going to take them right back to things they don't really want to remember.
There's so much around the emotional. It is a change in identity.
It's always a safe space to say whatever you want, ask whatever questions. I'm never going to tell anybody to explant. That's a decision you arrive at. I can help explain what we know, the current literature, for you to digest and make your own decision. I find a lot of testosterone suppression in the women we explant. Women need about 1/12 the amount, but they need it. When they don't have it, energy, focus, hair growth, libido, energy, all the things are affected.
Breast implant illness, is that a thing?
Yeah.
Is that kind of laid out as one of the risks?
It is now.
Recovery period for an implant versus an explant, what's that look like? What are the biggest challenges you face? Well, Dr. Rob Whitfield, welcome to the show.
Thanks for having me. I'm glad I could get out to Spicewood.
Yeah, heck yeah. For those who don't know, Rob's daughter and my daughter, way back when, used to play soccer together, and that's how we got connected. Our wives have maintained a friendship, and then you and I, we probably met sometime in the past when the girls were playing soccer, but we really got to connect probably at the end of the year at dinner, and it was great, and just fascinated with the work you're doing. And I would suspect that my audience skews a little bit more male than female, but it's probably not by much. And generally, I talk about things that are with regards specifically to men because that's what I am, and that's what I speak to that experience. And as I think about the work you do, it absolutely impacts men. Maybe not as much as the women, but I love your approach to something that's very common in the world. And I don't think enough people either understand what some of the risks and consequences are. And I think even when they do, there's so much underlying when they feel that the right thing to do is to move away from something that they've had in their body for a long time. It's still not as simple as you're going to feel better if you remove these things. There's still there's a lot of resistance because frankly, there's a change in how they look. And I mean, I'm really excited to explore this whole kind of paradigm with you because you've been let's call it an expert in the field for over 20 years, and you've done thousands upon thousands upon thousands of explant surgeries. And as far as I can tell, your approach is really unique and one of a kind. And what probably drew me to it the most is your holistic approach to the whole process. And it's not surprising the way you live your life. And so if there was a dissonance between you living this super healthy lifestyle and then not having that care transferred to your patients, I'd be a little bit shocked, but that's not the case. So welcome to the show.
Thank you for having me. I'm happy to be here. It's listening to you talk about it like that. I think what you said in terms of your audience. So what I do really affects males. It's obviously a big change if in your spouse or your partner or a family member who has implants, whether they were placed for cancer reconstructive purposes or cosmetic purposes, and then ultimately they have a problem or their health deteriorates and they feel like they've went through a very exhaustive medical workup and not found any answers, and then went to other kind of alternatives, whether it's a functional medicine or integrative type approach or acupuncture, chiropractic care. I mean, people find me from all sorts of avenues after, there's been a lot of, attempts to get better, feel better, without exploring this option, which is a surgery that's going to take them right back to things they don't really want to remember or deal with. Everybody has a lot of reasons. I've interviewed patients on my podcast specifically, and I'm always like really shocked by the things they tell me about what led them to the decision. Recently I had somebody on who was, um, you know, continually from a work perspective asked to get implants to enhance their marketability as a model.
Mm,
And I've had people tell me that from other countries, our export of the show Baywatch was a big influence on them. And Barbie dolls. And I mean, the list is uh, pretty long. And it's kind of, peer group acceptance within the moms that they see,
mm.
or that may, and then there's always the case where they didn't develop and they were bullied and made, fun of, and so they wanted to, as soon as they could, get the money, get an augmentation, and I think the one of the main things is, the 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 problem I have with how people get to me is all these stories are really pretty, um, I don't know, they're very myopic.
Really?
Yeah, they went and saw somebody for augmentation surgery, and the easy route was to place an implant. Depending on the age, that may be the only option. Really, really young people are lower BMI, lower body weight, less fat, and obviously that's one of the reasons they're looking to get an augmentation. And now I do something, and I have done something for cancer patients for a long period of time called a fat transfer. So you take
Mhm.
fat from one area and you transfer it to the other areas of the body. And it's done routinely throughout the world for buttock augmentation, for breast augmentation, and for facial augmentation. So the things that I'm concerned about is patients, depending on their age and maybe their ability financially, aren't really explained all the different options, and so that ends up being a very unfair, um, to the patient in a decision making process. Just everybody, should get the most information to make the informed decision that fits best for them, regardless of, resources. They should understand the options. And many times when people come to me, they had no idea fat transfer was even a thing.
Mm.
Because the best augmentation is always with your own genetic material, which is your own fat, barring a few exceptions. And if otherwise, very, healthy, person who wants to have a very natural result, that would be the option.
What if you're someone who's pretty lean? Is it advisable to use the fat from someone else? Can you do that?
So interesting, like the last surgeon to win a Nobel Prize, Joseph Murray, he performed the first kidney transplant in a Siamese twin. So it'd have to be a twin, basically, to have the exact same genetic material, then transfer. And this has been done because Bob Allen, who's a cancer reconstructive plastic surgeon who, pretty famous in terms of reconstruction, he performed what's called the DIAP free flap, which is taking the lower abdominal tissue connected to the blood vessels that run through the rectus muscle, the six pack muscles, transferring up to the chest and hooking them up to the blood vessels underneath that the heart surgeons use, the internal mammary artery and vein. And he did that in twins because it can't be rejected because it's got the same genetic material. So that's the only instance of it, because you would you would reject it.
Body would reject it.
Yeah. So when you're doing autologous, that means yourself, right? You're auto transplanting. You're taking it from one area and just putting it into another area. And that should work uniformly well. I always tell everybody the same things. The closer you are to 20, everything works great. The closer you are to 80, things, it's a little bit more challenging. So we have to take more care. We have to do really thorough workups. And you mentioned our program. We wrote a book about our methodology called Sharp. And it's really, the point of it is, you can't outrun a bad diet and you can't pick your parents. So understand your genetics and then your toxicity burden, dialing in someone's diet, getting them off ultra processed foods and increasing their healthy fats and proteins. And I don't really care what kind of protein diet you're on. I mean, my folks who are vegetarian struggle to get enough protein. So that's the only, rub in that. We do look at gut health extensively because most of your lymphatic tissue really resides in your and around your GI tract. So it's a lot to unpack by the time someone shows up and needs help. And then last year we published a paper that showed that on those implants I take out, the scar tissue from the patients, 29% have bacterial contamination.
Hmm.
So recently, it's been published that bacterial contamination can interact with the fatty acid oleic acid. So there's fatty acids in the breast tissue, and that interaction causes an oxidative reaction. So oxidative stress is like, we want to always be in a balanced state. So if we oxidate, or like when we work out, we create oxidative stress. We want to be able to reduce that. And when we exceed it, these not so good metabolites build up. And this one is called oxylipin-10-hum. And that can lead to many of the symptoms that we talked about. My patients get fatigue, muscle and joint pain. Those are just some common ones. And this molecule's, been ascribed to those symptoms. So, when folks are asking me like, why are you doing this? And, what's the consequence? Because it is a big deal. Like you're pointing out, that's the why. And then when we try to, it's not a reconstruction like I did for a cancer, but it's applying many of the principles where I take someone's fat like I did before I came to do this show.
Yeah.
Did a fat transfer this morning and it works extremely well. And in my hands, I've done several thousand fat transfers for cosmetic and cancer patients. It works well. And when you think of it, it makes a lot of sense. It's your own material. It has to heal where you put it. Any little bit of fat you put in the face to augment the face, and just see what Ozempic and Mounjaro and Wegovy do to faces. And there's going to be a whole slew of people getting facial augmentation because you already see it happening.
Interesting.
And, that's an, how do you want to say that? That's an event you don't really want to get into. So when you lose weight, and it's really fat that's being lost in your face, that's a huge problem because you're not going to get it back in your face. Typically,
Yeah.
your skin will loosen up, your neck will loosen up, and then gives you what they call Ozempic face.
Yeah.
And when I think of it, there's a group out of Argentina that has a very novel stem cell protocol that will help with the face and facial augmentation. But I feel like fat from other areas that didn't get completely caught up in that process will have to be used to at least augment the face and try to get a more balanced look. Because you're just trying to create harmony in the face. You don't want to have too much laxity in the face, especially at a young age. That just makes you look older. So facial fat augmentation works extremely well. And then the Brazilian butt lift has been around for ages. I wrote a safety paper, maybe 2017, 18 about gluteal augmentation because people were suffering some events from that, but it's more of a technical issue. So augmentation of the buttocks common. And the last, real kind of, I guess, a place where it should be like a very common, very safe, thought of procedures for the breast, except where there's this disconnect with, I think, somebody who gets augmented typically gets the fat behind the breast or behind the muscle, and that's the space for that. But that's not where fat goes when we auto augment the breast. It goes just like my pocket on the front of my shirt, it goes beneath the skin above the breast tissue. So there's only a limited amount of space. Just think of a pocket on a shirt. You can only put so many things in it. And then once it's full, you can't keep expanding that pocket. And that's probably why there's so much kind of consternation about the breast, unlike a buttock where you can just jam more fat in because the space is so large. The breast is obviously a different space, and it's got the glandular tissue behind the fatty layer, and everybody's got a little bit different thickness of the fatty layer. Obviously, lower body weight patients typically will have lower or less thickness, and then people are a little bit heavier, more. So this is the rub, right? How can I take care of that for everybody?
Yeah. Okay. So I have so many questions. First of all, SHARP stands for Strategic Holistic Accelerated Recovery Protocol.
Protocol or program, either one's fine.
Okay. So you talked about that, but specifically, like, this is very different than what was being done prior in the field, I would guess.
Yeah, when we were taught to work somebody up in surgical training, it was like get a basic uh, set of labs to look at your hemoglobin, make sure your blood count's fine, make sure your electrolytes are okay, and they would do, if you're older, an EKG, and back when I trained, I'm old now, a chest X-ray to make sure your lungs were clear. The people who are coming to see me are relatively fit people. They've already been worked up 7 ways from Sunday normally in the typical.
Oh, because they've tried to figure out what's going on and they finally realize it's the
they usually come in with a fistful of papers from different labs, and some people are doing some like we talked about, some functional workups and everything. The thing that I get concerned about is there's so many different types of providers trying to help. It's not coordinated. And then if you're just seeing 1 or 2 patients like this maybe a year or every quarter or every 6 months, I see like 40 people like this a week sometimes.
Jeez.
It's not really a thing for us to work up. So I don't engage with anybody anymore who doesn't want to commit to the process, because if you understand your genetics better, then you can really dial in what you should be doing. And then if you understand your toxicity burden, because we all have it, we all have lived in places, worked in places, traveled to places that have maybe high mold content, or we've been exposed to things in the food supply, glyphosates from food that's been, treated, and we haven't gotten those chemicals out of the foods. Or like I grew up in a place that had bad groundwater, so I had a lot of arsenic in my system. That's a very common contaminant in groundwater. And my dad was a nuclear weapons inspector, so I have beryllium in my system. It's never going to get out because it's not something you can just magically detoxify.
Sweet.
Yeah. There's always something.
Let's talk about, I'm so curious. So there's this, it's called, I believe, breast implant illness. Is that a thing?
Yeah.
Okay. So when I go in for an augmentation, is that kind of laid out as one of the risks? Is it kind of like?
It is now. I stopped doing augmentations with breast implants about 5 years ago now, not because I couldn't do them or it just didn't align anymore with what I was doing. So I'm trying to help all these folks, and it's fine to put them in, given full disclosure about what can happen and the options. And you're just doing that so the patients have all the information, and then the patient makes the decision. Like, I try to let everybody know, like, I'm not here and I'm never going to tell anybody to explant. That's a decision you arrive at. I can help explain, what we know, the current literature, and then give you that information for you to digest and make your own decision. It's not something that is to be taken lightly at all.
if you had to guess, when you're kind of explaining that as a risk back when you were doing this, how many women, and I guess sometimes they'd have their partner, well, man or woman there, how many of them kind of took that seriously, or kind of like you do when you're signing some shit, you're just like, yeah, just like,
Well, that's the problem. I think young people just sign stuff, and then as you gain life experience, you ask a lot more questions.
yeah,
And I always, kind of approached it in the worst case scenario. I would always tell anybody that got an implant, and I was a associate professor of orthopedics as well. So I worked with a lot of orthopedic surgeons doing reconstruction for sarcomas, and they put in these huge prosthetic devices to reconstruct your leg. And I mean, it was crazy, but all those things can get infected.
yeah.
And so whether it's a, knee implant, hip implant, dental implant, cardiac implant, neurologic, anybody who puts in any implant as a surgeon always has to explain and disclose that this can become infected. So I always gave that disclosure and discussed that. And I did a lot of cancer reconstruction, and those patients always had more surgeries and more problems. And then they had other therapies, like they'd have to undergo chemotherapy, which would immunosuppress them and put them at higher risk for an infection, or they would get radiation therapy, and that would put them at risk for problems with the skin over the implant. So there are
Oh,
all of these extra things that I just got used to talking with patients about. So I never was very, uh, you know, not even, it's not cavalier. I always had a lot of respect for the implant. Like, it's a foreign body and it can get infected. And because we did all these other surgeries with all those other adjuvant treatments for cancer patients, I was always getting called, hey, Mrs. Smith has a red breast now. She's being admitted for IV antibiotics. In 24 hours, if she's not better, we're going to have to take out her implant. I mean, that would happen when people were on chemotherapy.
well, yeah. So I come into your office 5 years ago, and I'm interested. What are the risks for me stepping into the implant space?
Yeah. So I would have been, if somebody only wants to go up a cup size, I would explain, fat transfers to them. And then I would say the risk benefit ratio for an implant doesn't make sense. If they wanted to go up more than a cup size and they were low BMI patient and still were, you know, on the like, no, I don't want to use my own tissue. I'd rather have an implant. Then you'd have to go through the whole disclosure of um, everything that's going on with implants. And for cosmetic purposes, I only used smooth round implants because those would have the least amount of issues. So if it rotated, it didn't matter because it was round. And it was smooth versus textured. Textured implants were pulled off the market in 2019 in Europe because there's uh, a lymphoma that can develop from a certain textured surface. And the, you know, the surface, the size, the shape, all the things, that's more of a, in-depth discussion. But if you want to keep it super simple, it's always like smooth and round. And then it's the filler, saline or silicone. For saline's always going to be firmer because you fill it up and it's more like a balloon.
Okay.
And then silicone's always going to be softer. So when you're a really, really thin patient, the more natural feeling device will be the silicone device. And then when you're a cancer patient, of course, the more natural feeling device after that operation, because it thins out the tissues so much, will be a silicone device. And those were, kind of the basics. And then you have to discuss all the bad things that can happen with any type of device, including infection and extrusion and removal because of those.
Is there a certain like kind of inflection point where it would be wise for women to have them removed and have fresh ones put in, or is that even something? people do?
Yeah, I got asked a lot about that. And so the way I was trained is they gave it like a 10-year shelf life, and they, trained us to discuss that starting, I was trained to discuss it starting at year 8. And I didn't treat my cosmetic or my cancer patients differently. I saw them annually, and I'd have that discussion with them, starting in year 8, because there's a 0.5% per year increase in the rupture rate. And if someone had, say, a cancer reconstruction and under surveillance, they had a change either on a MRI or ultrasound or whatever study they had, and it ultimately was worked up and they had a rupture, we would, of course, get them scheduled and exchange that device out. I never, ever, ever instructed a patient to keep a ruptured device. I know that I've gotten feedback from patients that they've been told that that's okay. And I don't, that is the most unusual thing to me.
Why would why would a doctor
Yeah,
recommend that?
I think it's dogma, really, because the capsule, the scar tissue that forms around the implant from your body is, think of like your knitted, quilt or something.
Okay.
Like if you pull it apart, you can see through it.
Okay. Yeah.
It's not impervious.
Mm-hmm.
And I think the problem is it's been thought that that's so protective that if the implant is ruptured and contained, it's fine.
Okay.
But it's not impervious.
Okay.
So we're just going to use science.
Yeah.
And the world is not flat.
Yeah.
That interaction can happen between the tissue and the device that's not intact anymore. And that, you know, anything that's in contact with your tissue that is foreign causes a reaction. And that revs up your immune system. Now, everybody will have a different response to that. I'm not saying that, everybody's going to get sick from that, but there's going to be a response unless you're immunosuppressed and you can't respond. So
explain that.
So if you're immunosuppressed, you can't mount a response.
Okay.
And that's why, when people are getting chemotherapy, they have really, really depressed white blood cell counts, and they don't want to get it too low. So they'll give them growth hormone stimulating factor. They'll try to raise it to keep them above a threshold so they don't get sick. So, but in everybody else who's normal, walking around, that will have a reaction. We just don't know exactly in you or I what's going to happen with that material in contact with our tissue. I already know that if it's not ruptured and I have bacterial contamination, I know there's an interaction back and forth, and this oxidative reaction takes place and produces a molecule that stimulates the immune system. I don't think it's really complicated to think that something that's ruptured and leaking would do something similar.
Yeah. Yeah. I think that seems logical.
Yeah. So I always advise my patients who, and my team knows this, if anybody calls and has a rupture, they get on my schedule as soon as possible so we can discuss, what things would look like for them, and give them as much guidance as possible. Because, people ask me, well, how urgent is it? Well, I don't know when this happened. If you just found this,
how do they know that it's ruptured?
They can, sometimes feel the change. They may have pain. I will tell you, like, if you can't actually feel the implant, that's not a good sign.
Oh,
that's typically, concerning because it's lost its integrity. So, or they may get a study like a mammogram or a mammogram ultrasound, and they'll be like, oh, this is definitely concerning for a rupture, and that may lead them to get a diagnostic study like an MRI.
Okay. The recovery period for an implant versus an explant, what's that look like?
Oh, when you get an augmentation?
Yeah.
Oh, those are pretty straightforward. If they're behind the muscle, folks can have muscle tightness, almost like crampy pain. So you would give them a muscle relaxant. And many guys and gals who do device placement do like what's called the 24-hour recovery. And it's basically anti-inflammatories and muscle relaxants typically. And that's pretty much what you would need for that operation. If it's above the muscle, it's like super simple. Doing explant surgery like I did today, those are more in depth because you're removing all that scar tissue.
Yeah.
So you're freeing that off the ribs, so the chest will expand more easily for the patient. They'll get better airflow or air movement, not airflow. And then when you're, typically reshaping or doing something like that, you're narrowing and lifting the breast. And then today I also augmented it with a lot more steps.
Yeah. I'm just so fascinated by this whole, like, I just, and I want to be careful because I don't know why, but I just feel like I want to be careful or just mindful. How immediate have you found women, they've been searching for this thing that's going on in their body and they finally land with you and you're like, okay, we're going to do this. And these symptoms and whatever they were feeling, how quickly do they see changes and what kind of changes?
Great question. I explain it like this. Nobody wants to come see Rob in Austin. Nobody.
You're like a dentist when we were growing up.
I'm like the little flagpole on the iceberg. Like nobody wants to be there. Everybody will do everything possible not to come see me.
Mm-hmm.
I'm the last person I want to come visit. And that's, by the time someone gets to me, they've tried all the things. They've exhausted a lot of time, effort, resources. It's created a lot of strain on them personally, probably professionally in their home life.
Mm-hmm.
And yeah, I mean, that's, it's, oh man, no, nobody really wants to see Rob.
But when they're done with their procedure and they're back home and it's a week later, it's a month later, like what changes are these women experiencing?
Well, yeah, I mean, that is interesting because I ask my patients who turn around really quickly not to post that on Instagram because, it's not a rainbows and unicorns type situation all the time. So it's not fair to the folks who have a more difficult recovery to see that because then they wonder why they're not doing better more quickly. Now, running our methodology with Sharp has helped change that paradigm. You don't have as many people taking as long to recover. So if everybody's familiar with the bell curve, we don't want anybody on the extremes of the curve. We want them all more towards the middle. So the Sharp method really in my career helps change what I've seen when people can't, won't, or have difficulty getting through the phases of recovery. So, we do a lot on the front end, as you know, like we're doing all this preemptively because you don't want to be responding to a patient who's having a difficult time. You want to make sure that you upfront know as much as possible about them, and that will help give them and empower them really to take care of themselves better after surgery and their partners or loved ones, whoever's helping them. And, people do great, who have more supportive situations. And I like it when I can speak to, their partners at the same time. So I can, kind of give everybody the lay of the land because can be very disconcerting. It doesn't necessarily fall into like a standard thinking pattern, like, why would this be causing a problem? And so when we do their explant, everybody typically who's flying into town to see me flies in the day before. We see them in the office. And, we have the office. I have a great team at my office. And the day after surgery, people are going to come in. I guess I should step back. All right. So when we see folks the day before, the night of surgery, I send everybody to the well to get a really good meal.
Heck yeah, I love the well.
And for everybody listening, so like most people can't access gluten-free, dairy-free, seed oil-free restaurants where they live. And so when I send them to this restaurant, The Well, I used to give everybody gift cards, but people wouldn't use them, which is very weird. So I stopped doing that. It's in my book though, so people ask all the time. So we have this series of prescriptions that we use prior to surgery to calm down the nervous system and reduce inflammation and help with nausea. It doesn't really help to do those things, quote unquote, after, because you want to avoid them, right? So for everybody listening, nausea medicine is not to be taken after you get nauseous. It's to avoid nausea.
Yeah,
Right? That's how it works. So we start all those things the night before, and then we have a very special relationship with an anesthesia group in town that I've worked with since 2018, and they perform nerve blocks before patients go back to surgery for me. So we've done all the work the night before. They've taken this. They've had a great meal. They've taken the things that are going to help calm down their nervous system and get them in a good situation. And then our anesthesia folks, who really do a stellar job getting them, really pretty comfortable before I ever do anything. And then we, do the case, and once the case is underway and I've gotten the implants and capsule material out, I go ahead and add this long-acting medication that helps numb the area more. So everybody the day after surgery comes to our office, and we have hyperbaric in our office, and we have lymphatic massage, because the best filtration system is not a drain tube. I don't use drains on people anymore. So we can avoid drain site infections and the pain that's associated with having a drain tube.
Where would I'm ignorant to the drain tube. Where would that be?
In the pocket where the old implant was.
Okay.
Because it's a space.
Okay.
So we don't use those, which is attractive, obviously, to patients, because they don't want drain tubes. And, if you got a male partner, they might be freaked out by that. You guys are not necessarily great in terms of, handling.
They're not great like you and I. That's right.
They're not handling the stuff. So we avoid that. And then we use these devices called Flowpresso from New Zealand. They're really tremendous for enhancing lymphatic drainage. And you do that, then a hyperbaric, and then we do a little red light therapy. And those have become, key in getting everybody in the right, space afterwards. You want to get them in a parasympathetic state and try to get them out of fight or flight as quickly as possible after surgery. And then, ramp up their protein, keep that high, and they can walk. And people stay in town about, a week. My people from out of the country stay 3-4 weeks.
They do.
Yeah.
And will there be like another checkup, like at the end of the week type of thing? Like what's that?
Yeah, when everybody's
post-op look like?
about to leave, well, they see my team during the week, and I try to see them all before they go.
And they're like what level of functioning are they on? They had surgery on Tuesday and it's Thursday. Are they sleeping okay? Are they walking around? What's
Yeah, I mean, I want everybody up the next day coming to the office. Like if you, the thing that I talk about it all the time, and I mentioned it as a priority of mine in my book, is sleep. Like if you can't get enough sleep, we talked about this actually when we were at dinner, the quality and quantity of sleep are extremely important. If you can't do that, you have no shot at recovery.
Yeah.
So it doesn't matter if you're having surgery or not having surgery. You got to concentrate on sleep. And, all of us who are I'm 55 now, and I've had sleep apnea diagnosed. Oh gosh, I don't know how many years now. Been wearing a thing at night to sleep, so my poor wife Ashley doesn't have to get woken up by me snoring. And I do it because it's extremely important for brain health to, obviously, you have sleep apnea. So, have a CPAP device and use it, not just look at it on your nightstand, but use it.
Yeah.
And then, wearables that we have now, like the rings and the watches and the straps and all the stuff, at least help you get an idea of how you're sleeping. They're not all, perfect, but you're trying to get 7 to 9 hours, especially after surgery. And your HRV, your heart rate variability, is something that I pay attention to and try to help people understand that that really is your metric for recovery. So there's a lot to explain in my program for somebody who's not super dialed in, but I have so many biohacking patients. They're kind of my worst lot though, because they're always trying to do
Too
too much
much.
stuff.
Oh, yeah. Interesting. Well, I think it's a great service. You're probably opening up a lot of people to, this whole suite of ways to care for yourself, that they can do themselves. And they have to do it during your protocol so they get some experience with it.
I mean, it's more of it's our lifestyle. So I ate at the well last night, and I wore my CPAP overnight. I wear my ring right now after I got done operating, and I bring all my own food in Caraway.
Yeah.
Uh,
Those are great containers. I got some recently.
and you got to avoid. I told my wife, I'm like, you got to get rid of. I don't care if the Pyrex has a plastic lid on. I'm not putting a plastic lid on my food ever again.
Mm-hmm.
So, I mean, whatever we can do to, minimize exposures, I'm like an air freak now. I have an air filter like almost in every room at my office and every floor of my home. And I mean, you can control your air quality. Everybody can do better with that. You can not drink out of plastic. You can drink out of glass and stainless and ceramic, and you can cook out of stuff that's not got Teflon, for God's sakes. You can do a better job.
Love that. Let me see if I get this. Do you use nerve blockers? Does that mean there's no anesthesia?
No, it's just an adjunct. This is too stimulating to do just under local.
Okay.
So we do that so that our patients are getting what they need to be completely anesthetized, but it's to really avoid narcotics after surgery, because that's what promotes nausea and grogginess and lethargy and just being tired.
Yeah.
And most people don't really want to take any of those things. And the more we can do to help them avoid it, that's, what we're trying to strive for all the time.
How is your work, influenced others? What are you seeing? And obviously you have the podcast, you have the book. What other kind of things are you working on, or do you have out there that are really educating other doctors in this space?
Well, I mean, we published a paper last year, and I think the way that I have to go about this to help people is we have a lot of understanding of the problem now. We understand that, we'll say 29% have this bacterial contaminant, and that's really contributing. And you're going to say, well, all right, Rob, well, what's going on with the other 71%? And I think that really consists of, or I feel strongly that it consists of a genetic predisposition towards poor detoxification. So it's almost like being set up.
Mm.
So everybody's heard of the MTHFR gene, and I got everybody, using the curse word routinely in the office to let me know they have it.
Mm-hmm.
Like, okay,
Mm-hmm.
I have it as well. But the point of it is that's just a component of a pathway of methylation. And we have problems in other pathways, how we synthesize our vitamin D. Like you'll hear a lot of people have trouble with the vitamin D levels, and women especially are susceptible because it can lead to osteopenia and osteoporosis as they get older and they lose estrogen. So there's a lot of things that collectively go into it being a more difficult problem. But I think genetic predisposition, and then that just plays into if you can't detoxify what you're exposed to well, either through your diet or your air or your fluid or your work or your skincare products, whatever it is, you're going to build up more and more in your system until your body can no longer cope with that. And that's when people become more and more symptomatic. And then, obviously I'm taking care of female patients, hormonal problems, estrogen toxicity play a big component in this. So it's not going to ever be a really super simple thing to explain across the board to all the providers. I just got very interested in genetics a long time ago in college. which is a very long time ago.
Yes, sir.
And the Genome Project was completed for everybody who's listening.
Mhm.
And we learn more and more all the time about genetics. I think that's one of the more interesting, aspects of just getting, and being healthy in general is understanding your genetics. So we focus a lot on that. And I think that's the next paper I hope to get out this year is what we found in terms of genetic predisposition. So we've established very, very firmly that the rate of bacterial contamination is 29% in the specimens we've explanted. So I don't really, need to hear any more feedback from people about that. That's out there, and that's to me that's the largest series in the world for this problem. If we then proceed to show the genetic predisposition is X, so maybe it's everybody has, a methylation problem in my patient population
Mhm.
or a vitamin D problem. Like I need to get that out there so it makes more sense for the patients, the providers at, any level need to be more aware so they can understand that. They need to ask too. Like I feel like this is such a like cloak and dagger thing. Like people don't disclose they have a device. Sometimes you just forget. And then it's incumbent upon the providers to always be asking on their questionnaires and then their interviews of patients if they have had any surgeries.
Oh.
And you sometimes have to be a little bit more clever about how you ask these questions. But you have to ask the questions in order to, you could miss this whole problem because it's not disclosed.
You mean because they didn't
They don't want to talk about it.
Oh,
They don't want anybody to know they had that done.
okay. And so that makes it more difficult because normally I would assume that if an educated doctor is looking over a profile and the questionnaire, and it's like, that would be something that's like, oh, that might be something to look at
If it's listed.
if it's listed.
Yeah. You miss 100% of the things you don't ask about.
How difficult have you found it in the women you've met who have come in, let's say outside the kind of the women dealing with cancer that have come in and they have some issues going on and you're the last person they want to see, but they're finally seeing you and they're like they're at that point where
Yeah.
they know they can no longer hang on to these things. Like what, like emotionally, like what, like how do you hold space for that? Like what is, how do you sit across from that?
Yeah, we let them know that it's, what I've done in terms of team building is unique. Like I have someone is at every level of the organization basically been a patient of mine. So my patient concierge has had an explant with us, and my medical team, there's a member who's had an explant with us. Our detox team has had an explant with us. Our administrative team, which members had an explant. So every level has somebody.
You got all these different teams. Wow.
Well, uh, you have to have people who can communicate the problems. I obviously can do the surgery, but I've never had the surgery.
Yeah.
I can't put myself in that spot, but I have people who can. And it's always a safe space to say whatever you want, whatever's on your mind, ask whatever questions. And I'm just, if you listen, people will tell you exactly what's going on. Just have to listen.
Hmm.
So I don't really listen so much to make a diagnosis of anything anymore. I'm kind of listening to genetically understand how someone detoxifies and what are their exposures. Did they live in a moldy environment? Did they get exposed to chemicals maybe as a kid in the Central Valley of California because they grew up near ag and they got sprayed with glyphosate as a kid?
Hmm. Damn.
Those are not good events,
No.
but people just kind of, they don't really think about them. You're not really educated to worry about that. I mean, we should be concerned about those
Yeah,
things.
but we're not at all. That's not.
No, when you're younger, you don't, you're not really paying attention. So I try to just be is like I always calm and just listen and,
You calm? I'm so that
let,
surprises me.
let everybody just roll with whatever it is. Cause it's very emotional for them to do the download. And sometimes they maybe listen to some shows or something spark their, you know, um, interest to finally come and have that conversation. Cause once again, it's a difficult one. It'll be really, it's not one that anybody's like, oh,
Yeah,
how do we see Rob?
you get to go do this. Yeah.
Yeah. Wow.
Maybe this isn't even a question you can ask, but I'm gonna or answer, but I'm gonna ask it anyway. What percentage of the women who've gone through this process have had regrets down the road that they did that process, that got the
It's
explants?
interesting. Somebody was talking shit about me on a show recently without saying my name. They were saying something about me.
You knew it was you?
Yeah. And they said there was this big, group on Facebook that had regrets after explant. And I was like, okay, well, I don't know. So I go and look it up and it's got, you know, a fair amount of people, like 10K in it. And then typical other groups who are concerned about the problem have a couple 100,000 in it.
Mm-hmm.
And so we'll do the math here.
That feels like
300,000 plus implants are placed in America annually, 300,000. In the world, 2.2 million are placed annually. And I told you like 29% have the problem. So we'll just say a third, over 10 years, you got 20 plus million, third of that, you got 6.6 million. Now, I don't want to say our program is perfect, but if you do all the things we're asking and engage and commit, I'm pretty confident that there'll be a lot less in the regret versus the, recovery with, the potential to really get healthy and feel well again. Our goal is just, we want to make everybody feel better and, feel and look as natural as possible. I don't approach it really any other way. We're always learning and trying to get the program, better for patients. That's all 100%. The hero in the story is the patient, and that's what we're trying and always striving to help.
what are the biggest challenges you face?
People don't do enough self work. They kind of expect us to do the work for them.
The not a quick fix, but kind of a quick fix.
Yeah, yeah. And so, I probably spend a lot more time talking about getting yourself into a parasympathetic state and concentrating on things like resonant breathing, not breath work. I don't want anybody. So this is not good after surgery. Breath work is not something you should be engaging in after surgery because it can make you hypoxic by breathing rapidly. So I concentrate and try to help my patients concentrate on what's termed resonant breathing. So, just getting yourself into like belly breathing like a baby. So that lowers your, we'll just say your stress state.
Mm-hmm.
And if the easy way to do it is when you're in bed in the evening and you're trying to get to sleep, is you can concentrate on breathing through your nose, out through your mouth, and do a count of 5 and do that for a few minutes. And we all could probably do a better job doing this.
Mm-hmm.
I don't do it with my CPAP on. That's a little challenging. And then before you get out of bed in the morning, you can also do the same thing. So that you have to take time for yourself. And I think the women in uh, in my experience, they're working so hard to take care of the family and they're running the household and jobs and not doing a good enough job taking care of themselves. So I have to have this kind of conversation where There's a lot of self work that's not happening that needs to happen in order for people to get well.
I think that's a huge point just from where I sit. Obviously you can put all the protocols in front of them to do the kind of almost like physical self-care, but there's so much around the emotional. It is a change in identity, whether, you want to look at it that or not. I mean, you're going to be different. Just like when you had the augmentation, it's a change in identity. And if you kind of rush into this and don't do the kind of go through the proper stages of kind of letting go of that old version and welcome in the new version. I mean, hopefully you'll eventually get there if you don't do that work, but it's going to make it really challenging. And I would imagine there would be a lot of emotion that comes with it. There's going to be emotion anyway, I'm sure. But like, if you could really just get like, if in a well-grounded mental state, and that does go along with what you said with the parasympathetic, obviously, and just be an acceptance of
I
it.
mean, everybody could do some therapy. I mean, that would be great.
Mm-hmm.
And there's nothing wrong with it. You know, probably all could do some therapy, a lot more therapy, actually. But for this, if we're not the therapists, I tell everybody I'm not a psychiatrist or psychologist. I mean, I tried to employ one because I feel it's important aspects of recovery, but it's also important to just get yourself into a better space before you ever do anything. Because, I just by operating as I'm increasing everybody's cortisol and their stress and putting them in the fight or flight. And then we do everything we can to get them out as quickly as possible. But, you know, one of the reasons I have people stay here is so that they can get some self care versus just immediately go back home and be back in their environment and in the same loop, doing the same things. Maybe they're not really good behaviors that don't serve them. So trying to, everybody kind of jokes. I send everybody to the well. My patients see me eating there all the time. But, if you don't take care of your body that way, once again, it's going to be very hard to recover. So everything you put in your body helps you heal, perform. It's going to help you sleep better and rinse and repeat. And that's how you get better. They're just tiny habitual changes that you have to make in order to get better.
Mm. Is there anything else you want to share about the work you're doing?
Yeah, for everybody who's considering or listening, like Cal said, the audience is mostly male. Like, if you don't think this affects you as a male, you probably are as dumb as you look. Uh, the problem is always the same. Like, if your wife doesn't feel good, is losing her hair's falling out, she's stressed out, she's anxious, she doesn't have libido. This should really concern you because I find a lot of testosterone suppression in the women we explant. And so for everybody listening, males can go through menopause, early in life and need TRT. Um, Mine was I guess I was 49 and I got, I went to my doctor and I was complaining. He's like, "You just sound like you need some testosterone. You're all whiny." It's like, "Oh, okay." Um, so consequently, women need about 1/12 the amount. They have but they need it.
Yeah.
And when they don't have it, energy, focus, hair growth, libido, energy, all the things are affected. So this affects you guys if you're listening. So pay attention. You have a, spouse or a loved one, you have a family member, probably an aunt, maybe your mom, maybe your grandmother. I don't know, but you should pay attention.
Yeah, I love that. That's a great message because I would say your partner is going to, part of the journey is that you'll still love them the same without these, could be big old fun boobs that you like to play with. And I've heard guys talk about that they're not that supportive. They're a little bit on the fence. And I'm like, kind of like, fuck off. Seriously, dude? Like, we're talking about your partner's health.
Right.
And you just want some bigger titties to play with? Like, what are we doing here?
Yeah, we've had people, unfortunately, experience this where their partners or spouses left after surgery. And I mean, left, took off. And so that's obviously a very difficult thing. And I have the same message like, that is not the person you want to be with anyway.
Yeah.
They're not the right person.
Yeah. You got some clarity. It's painful in the beginning, but you're better in the long run if they're gone because of that.
Right. Absolutely.
Well, where can people find you?
Well, I'm like a bad penny. I'm everywhere. So I think if you're interested in learning more about explant and surgical recovery, we wrote the book Sharp to make it very simple and easy just to learn the process. Now, if someone wants to learn more about, patient experiences and, maybe learn more about, how we view breast implant illness and our thoughts about it, we have a podcast, Explant Surgery and Recovery. I've been on a bunch of shows. One of my favorite patients of all time is Lauren Bostic, who's here in Austin, the skinny confident.
Yeah.
And Lauren was cooking herself in a barrel sauna multiple times a week. And she had this example of heavy metals on a toxicity test that still rivals anybody ever in my practice. But like, you can listen to her podcast, and I mean, she's about as frank as you can be.
She's amazing. Yeah.
And that's what I ask folks to do who are interested in learning more about, what to expect and experience. And then obviously, if you want to, connect with us, just go to my website, drrobertwhitfield.com, and you can, chat with my team and get something set up. But try to learn and get some things under your belt. I've done so much work to answer your questions that you can you stalk the death out of me without ever having to commit.
Yes, I love that. Well, Lindsay will link to all that stuff in the show notes. Thanks for being here. Thanks for sharing all this. Thanks for doing the work. Yeah, amazing, brother.